Hey everyone, thanks for joining me for another component of our concussion lecture series. This module is going to be part 4 with focus on intervention planning for patients with post-concussion syndrome. And there's a couple of big picture things to keep in mind before we move too far into this lecture. Number one, we spent quite a bit of time discerning how patients can be classified into each of the major clinical profiles. And one of the biggest reasons we've done that is because a lot of the evidence supports certain interventions based on whichever clinical profile that person presents with. So there's great evidence to support certain interventions when that patient falls into a vestibular category versus falling into an ocular category. So, we're going to kind of talk about each one of these clinical profiles and provide some information on kind of what to target for your intervention planning based on each profile. Now, that being said, unfortunately, most patients post-concussion in the real world don't actually present with only one clinical profile of symptoms. Most patients with post-concussion syndrome are probably going to be more like the rest of the patients you treat that have more of like a primary impairment category with secondary and tertiary categories. So I don't think post-concussion syndrome is any different. I think you're going to have a primary clinical profile with, a couple of secondary or tertiary types of issues happening where, you might focus your treatment more on that primary profile, but it's important not to forget about the management that you're going to need to do for some of those secondary and tertiary issues. Okay, so even though we're going to present it kind of, here's this one thing to do for this person when they have a vestibular profile, just note that they're probably also going to have some fatigue issues and reports of headache that might be tied to their cervical spine, and they might have anxiety. So just because you're keying in on vestibular doesn't mean we ignore all of those other symptom profiles as well. Okay. The next thing to consider is that while we do have a lot of information specific to each profile, there are some big picture overarching themes of intervention strategies that are appropriate really for any patient post-concussion, regardless of the clinical profile they're in. So we're going to kind of start big picture, talk about those overarching themes of treatment strategies, and then we'll narrow down our scope into each one of the clinical profiles. Okay, so let's start with a big picture overview of PCS management. And again, because patients with post-concussion syndrome can present with such a wide range of signs and symptoms, it's important to note that, probably a multidisciplinary, collaborative type of care approach is going to be best for this patient. There might be certain signs or symptoms that we as physical therapists are well positioned to be able to be the primary care manager of. But then there are going to be other types of signs and symptoms where the best option may in fact be referral. So keeping in mind that, we might need to continue to have that MD involved for medication management or referral to a psychologist or psychiatrist for cognitive behavioral therapy or things of that nature, stress management techniques. Some of these things might require referral. And so to optimize recovery for that patient, most individuals will really need a collaborative, multidisciplinary approach to patient management. Another big picture thing to remember is if you're working with a patient that has a sport-related concussion, return to play is going to be a big goal overview for that particular person. And we have some pretty good evidence out there about return to play decision making and criteria and kind of how to approach working that patient back to their return to sport. And so we've tried to apply some of those similar principles to other types of activities, like, guiding decision making on return to school related activities or work. But unfortunately, we haven't seen as good of success with using those similar types of decision making modules for return to other types of activities like we have with return to sport. So good evidence for return to play, poor evidence for return to other types of activity. So what we'll find is kind of using symptom provocation as a guide tends to be one of those better tools to make decisions about, well, how do I ramp up my activities at work and how do I return to my school-related activities? So we'll talk a little bit more about that as this lecture series goes on. As far as exercise goes, exercise is good, but in moderation. What we're finding in the literature is that if you can get that person to a level of moderate exercise, especially if it's aerobic in nature, that tends to be most beneficial for the patient's overall recovery. It used to be that following a concussion, for 24 to 48 hours, the best recommendation was bed rest, complete rest, remove all physical activity, all cognitive strain, and you need pure rest. And what we found out is that actually leads to a negative impact on recovery, a prolonged recovery. And we find similar information for those that return to normal activity or high intensity activity right away. It's really not indicated to have an exercise intensity that's too high or too low. We kind of want something in the middle if at all possible. In addition to that moderate level of exercise, research shows that if that exercise is sport specific for someone that's had a sport-related concussion, you're probably going to see the most optimal outcomes in return to play types of decision making. For everyone else that's not a sport-related concussion, then targeting function seems to be the most beneficial form of exercise planning, big picture. Let's talk a little bit more about subsymptom thresholds. I kind of like to look at this process as like a dimmer switch, right? So just kind of thinking about, how you can kind of ramp down the lights into a level that, works well for you, that doesn't actually exacerbate or provoke further symptoms, all right? And so we really need to define what that subsymptom threshold is, because that's going to be a major guide about how intense or how long or what kind of environment that we can engage these interventions in. So there's a little bit of give and take with regards to subsymptom thresholds. There are some people that interpret that literally. You can't have any increase in overall symptoms. I think that's a little strict. I've had some doctors be more along the lines of greater than 2. So if that person comes in with a headache at a 3 out of 10 and we start doing an intervention and it moves up to a 4 out of 10, probably okay to continue that intervention. If it goes to a 5 out of 10, we're starting to, monitor it even a little bit more closely. If it starts to get above a 5, then we need to ramp that activity down or discontinue it, right? So most commonly, the subsymptom threshold for most physician is labeled at a 2-point increase in whatever their symptoms are. I tend to be a little bit more conservative and kind of go for that 1 point, especially early on. So if somebody comes in and they have a dizziness rating of 4 out of 10 and, we start doing an intervention and it gets to a 5, I'm typically okay with that. But the second it starts to get towards a 6, I'm going to ramp that back down again. So clearly classifying what that subsymptom threshold is for your patient is going to become really important, because you're going to use that basically as a guide to minimize the intensity and the effort and the duration of that intervention to not provoke further symptoms above that threshold. Another big picture overarching theme is sleep. Sleep is incredibly important for this particular patient population with regards to recovery. Healing happens more during your sleep cycle at night than any other time during the day, right? So this becomes really important for their overall brain health and recovery process. Sleep is one of those things where most patients post-concussion report issues with. And so there's a few, recommendations from a patient education standpoint that I'll make for pretty much any patient post-concussion to kind of help improve their overall sleep quality. Number one is to avoid daytime naps. And I know everybody without a concussion is saying, I love naps. They're great. I wish I could have a nap every day. I agree with you. But what we tend to find is that with a patient post-concussion, they're already having a bit of an interruption of their normal circadian rhythm because of the injury mechanism itself. And so adding in naps throughout the day, unfortunately, further interferes with their ability to then tap into that circadian rhythm at night, and then they have a poor night's sleep. And unfortunately, that's the time period where I really need them to get a nice, long quality nighttime sleep so that we can have brain healing occur. So we really want to encourage 7 to 9 hours of nighttime sleep and try and prevent daytime napping. Okay. This particular patient population also benefits greatly from preparing for sleep at night. So, taking, 30 minutes before, when you're about to go to sleep to relax and to breathe deeply and to de-stress and uncharge actually helps to set up the person for a better night's sleep. So this is the person I'm encouraging, to turn off their phone and not watch TV and put their laptop away. And this is the person you don't want exercising late at night, and you don't want caffeine later in the day or even at night, because those kind of things are stimulants that can keep their brain active, and I need them to start working on the process of shutting down in preparation to sleep. That's how important sleep is for it. Okay. Patients typically, really anyone, I shouldn't just say patients, anyone typically sleeps better in a little bit cooler environment. If it gets too warm, typically those patients will wake up more frequently, and it interferes with their ability to sleep. So, try and encourage them to get in a room that's a little bit cooler, that's dark, that doesn't have blue light, that they can just kind of get in and relax and prepare themselves for sleep, the better off their sleep is going to be. So this is a huge component of what you're going to do with your patient education. Okay, so those are the big picture pieces that I would recommend really for any patient post-concussion as part of their individualized treatment plan. Now let's talk a little bit more about each specific profile. And again, remembering that we're going to present this, kind of in a compartment or in a box. Here's what I would do for this profile, but just remember that your real life patient's not going to be probably classified in only one of these profiles. So you may have a treatment plan that involves approaches for multiple different profiles. Okay, let's talk cognitive fatigue first. Patient education is probably the number one most important thing you can do for this individual. Again, sub-symptom threshold education is going to be hugely important for this patient population, especially because they're going to be reporting significant issues with fatigue. So as part of your education on sub-symptom threshold, you're also going to be trying to discern how long of the activity they can tolerate before they start provoking those symptoms, again, either greater than 1 or 2 points of what their current symptoms were. So you may need to limit those cognitive activities for someone in this particular category to shorter intervals, maybe something like 30 or 45 minutes before they need a break. And you're going to encourage frequent rest breaks. I don't know if you've talked about fatigue management with other patient populations, like congestive heart failure comes to mind right now in cardiopulm, where I'm going to encourage that person to kind of distribute their errands and tasks throughout the day and work in more opportunities to take rest breaks, because then that allows them to be a little bit more functional for a longer period of the day with less overarching symptoms as they go through. A person with CHF, I might even, recommend a walker, just because I know that reduces their energy expenditure throughout the day. So a similar kind of thought process with this particular patient profile is we've got to figure out a way to kind of give frequent rest breaks and distribute the tasks that they have, so that they can go through more of the daily tasks that they need to do with less overall symptoms. This is the patient profile where you need to be really careful about them overdoing it too quickly. These individuals might feel good in the moment and then kind of overdo it, and then all of a sudden, they're having significantly high symptoms and they can't get them calmed back down again, and we have a setback. So really encouraging that they kind of limit themselves to shorter bursts of activities, especially if it relates to cognition, and incorporate more frequent rest breaks throughout the day. As far as specific interventions, we're really talking about those individuals that tested poorly, maybe on the impact in multiple different categories. So things like memory could be involved, attention, focus, visual reaction time, problem solving, et cetera, et cetera. So any interventions that we can do that kind of relate to cognitive training would be indicated. So this is the individual I might play that classic card game memory with, where you flip over, two cards and see if you can, get a match, and you try and remember where each one of the cards pictures is located. And this is a fun, great way for them to actually start working on their memory recall. There's also good apps out there that you can do, something like a Brain HQ app, or CogSmart is another online system that helps with training in a lot of these particular categories. Again, keep in mind that the goal is to be able to do some of those cognitive activities in short intervals. So they may have used that app for a short period of time, then they need that rest break, then they can come back to that app again later. Just don't encourage them to overdo it. There's three other major things that I think are underrated when we talk about overall cognitive health, brain health in general. Aerobic exercise, especially if it's in that moderate category, has been strongly proven to improve cognitive functioning. It releases neuroprotective factors. Aerobic conditioning is excellent for this particular patient population. Just remember, you're also dealing with fatigue. So they might not be able to do all of that aerobic exercise prescription in one bout. They may need several smaller bouts of aerobic exercise interventions mixed in throughout the day with good rest breaks in between. We also find that things like meditation and mindfulness are incredibly underrated with regards to their protective factors for cognitive health. So those are things that I will consistently try to encourage the patients engage with, teach them how to use some of these tools with regards to mindfulness and aerobic conditioning in order to improve their overall outcomes. Okay. Again, this is somebody that might benefit from referral for a cognitive therapist or a neuropsychologist. They might be able to have some tools in the toolbox for improving overall cognitive health. Okay. All right, let's move on to the post-traumatic migraine profile. For the post-traumatic migraine profile, probably the most important thing you can do is refer. This is a person that needs some sort of headache specialist, whether that's an MD or a neurologist, etc. They need somebody that's really skilled in how to manage headache symptoms, particularly from a medication standpoint. It's really important that this individual find the right medication for them, because there's a lot of negative side effects from migraine medicine. And so finding the right fit that works for each patient requires a little bit of assistance and specialty from that MD. This person also might benefit from referral for counseling or from therapy to improve stress and improve coping strategies, because those are commonly trigger mechanisms for individuals' migraine. So if they can have better coping skills to manage the stress of everyday life, the less likely they're going to have a migrainous event occur. From the physical therapy standpoint, it's really important that we engage in a lot of patient education. That can still be our role. And again, remembering that, while we might classify someone in a primary category of post-traumatic migraine, that doesn't mean they might not have secondary issues like cervical issues or oculomotor dysfunction or mood anxiety problems. There's other things we can still play a role in besides how do we prevent the migraine from occurring itself. Okay. But for this particular person, I would highly encourage them to keep a headache diary. It's really, really vital that this particular patient be able to track potential triggers of their migraine attacks. When do they happen? What are factors that kind of led up to that? How long did that migraine last? The last time I had a migraine, was it a similar process? So keeping a diary of these headache events becomes really important, because the best way to treat somebody in a post-traumatic migraine profile is to identify and hopefully prevent the triggers of migraine from occurring in this person's life. So lifestyle modifications are huge, right? So the literature reports a lot of really common triggers. And so there are certain things that you can kind of key them in on if they're having a hard time figuring out, like certain foods could create it. Stress is another one. Sleep hygiene is another one. Environmental factors can be common, especially lighting. I don't know how a lot of you feel about like the fluorescent lights in our classrooms, but man, they hurt my eyes, and I don't even have a migraine going on. So those can often lead to triggers of migraines. So again, this patient population commonly sensitive to light, commonly sensitive to sound. So even just some environmental recommendations to make adjustments for can be very helpful for this person's management. From a mood anxiety profile, again, one of the best things that you can do for this particular individual is to refer them. Again, they may require medication management. They may be better off with therapy or a combination of the two. Cognitive behavioral therapy is strongly recommended for this particular person, and how to manage mood and anxiety and all the frustrations that they're feeling with regards to the recovery process post-concussion. From our standpoint, there's a couple of things that we can do to encourage improvement for somebody in this category. And from a physical standpoint, anything where we can get them moving is actually good. Especially from an aerobic exercise standpoint, it helps to release endorphins. People that exercise feel better. It improves their mood. It stabilizes their anxiety. It reduces stress. Much like you've kind of talked with other types of patient populations, like like a chronic pain standpoint, it's not really a specific type of exercise mode that's indicated. You really want to be non-specific with your exercise prescription. We're not trying to treat a specific impairment with regards to this. We're just trying to encourage movement. So some of the most commonly studied things that improve mood and general exercise health include yoga, aerobic exercise, meditation, and mindfulness. Those are things that I would highly encourage you to incorporate with a patient that falls into this mood anxiety profile, because they get the person moving. And something like yoga, there's a physical movement to it, but it also can pull in elements of mindfulness and meditation and stress management and coping strategies. All of these things are necessary for a person in this particular category. Another thing is your education on sleep hygiene. That's crucial for this particular person. Think about how you feel when you don't get enough sleep. Now add into there that you have this mood or anxiety issue on top of it, with maybe poor coping management strategies on board. Sleep can become a really big issue for someone in this particular population. Okay. And also remember back to when we talked about this profile in general, this is the individual that tends to withdraw, so they're trying to find ways to kind of isolate themselves away. So you want to encourage social interactions. You want to stress the importance of support systems. I will just say that I might encourage them initially to kind of limit the size of their social activities or how long they do those activities, and kind of use, again, some symptom thresholds to help guide that. Let's start small, create some opportunities for social engagement, but shorter periods of time with less people, and then we can kind of ramp up those opportunities later to get them really more fully engaged in society. Okay, so those are last three are our big picture categories, where we don't have a lot of those elements built into the APTA CPG intervention domains. Okay, so the APTA put together a nice clinical practice guidelines for how to approach intervention that are a little bit more specific to what we do in physical therapy. And so some of those domains best suit some of the clinical profiles that we have, like cervical spine profile, or the vestibular category, or ocular. We have great interventions from a physical therapy standpoint that we can use to address those. It's a little bit harder for us to have a nice CPG for how to improve somebody's mood, or for how to address post-traumatic migraine. So while there are certain roles we can play in some of those other ones, it's not as clearly prescriptive as some of these other categories are. Just to note, somebody in that cognitive fatigue category, they might fit every one of these CPG intervention domains. So just note that, that particular profile can present so many different ways that some of the things we're going to talk about, even though, they're in other profiles specifically, it still might relate back to that cognitive fatigue category. Okay, so let's talk about the four classification domains for intervention that the APTA has established for us as clinical practice guidelines. The first is the cervical musculoskeletal category. They combine vestibular and ocular together into one category. There's a category for exercise intolerance, so that person that comes in and they're having difficulties with dysautonomia or being able to engage in exercise again based on maybe what you found on the Buffalo concussion treadmill test, they might fall under that. And then motor function, which is usually where we start talking about things like balance, dual tasking, things along those natures. So let's break down each one of these areas. So the APTA CPG domain is cervical musculoskeletal interventions. This is heavily implemented in a patient that falls into the cervical profile, and exactly how you're going to treat this particular patient is going to be dependent on what you find in your examination. What I have listed below that is really more of the most common types of signs and symptoms that you'll find in your cervical spine examination. They may have some of these, they may have all of them, they may only have one of them, they may find something completely different than this, but here are the most common, right? So from a strength standpoint, oftentimes what you'll find with this particular population is poor deep flexor endurance, poor activation of those deep neck flexors, and you'll see considerable substitution of those superficial flexor muscles. And that becomes important because if they're overutilizing something like SCM or something of that nature, and they develop maybe a trigger point or issues within the flexibility of that particular muscle, that can really start to influence headache pain. Referred pain from the muscle from SCM goes to the head. So there's some reasons why we kind of want to engage those deep neck flexors and start to calm down or reduce the utilization of those superficial neck flexors like SCM. Okay. Also common to see somebody in this profile lack range of motion or flexibility of the neck. This is a patient population where you're probably doing a little bit more of a mixture of manual therapy with exercise. Just make sure, again, that you rule out any sort of potential risk like a fracture or hypermobility, instability of the cervical spine region. But the most common presentation for somebody in the cervical profile is technically to end up with a little bit of a lack of range of motion, particularly the upper cervical spine region. Postural dysfunction is another thing that you'll commonly see for this profile. And from a sensory motor function standpoint, in particular, when patients have a traumatic type of mechanisms, such as like a whiplash type of mechanism, what we tend to see is some significant deficits in proprioception and kinesthesia. So we want to make sure that we test for that and treat for proprioceptive awareness of the head and neck. All right. They may also have associated whiplash signs and symptoms that we need to work through, or associated cervicogenic headache that we need to work through. Again, most of that is going to involve the upper cervical spine. If it's coming from the neck, it's usually C1 through C3. It's very uncommon to have the lower cervical spine produce any form of headache referral pattern. It's usually the upper cervical spine taking you back to your anatomy and where those nerve roots end up moving out within the extremities. Evidence-based practice indicates a multimodal treatment plan. I think I said that earlier. So this is the patient population where manual therapy is indicated, but you're probably doing that in conjunction with exercise as well. So typically we don't do manual only and we don't do exercise only. We find the best results for somebody in this particular category really needing a mixture of both. And don't forget to assess this individual for trigger point dysfunction. Very common to have trigger point, active trigger points in this particular patient population. Treat it if present. If you can dry needle it. If you can't, then you go through some more of the soft tissue techniques you would do to kind of interrupt that trigger point cycle. As far as further specific interventions go, address their spinal mobility, address myofascial restrictions, particularly in the suboccipital region. So something, like soft tissue to the suboccipital group, or there's a manual therapy technique called a suboccipital release, which some of you may have experienced or tried before. Anything that you can do to kind of improve that overall mobility, again, particularly to the upper cervical spine region, probably going to be most indicated for this particular population. Okay. From a neuromuscular reeducation standpoint goes, we need to improve their overall neck proprioception and kinesthesia. We can detect that through a joint position error test. Usually that will give us some information about how significant that deficit is. And then there's some training things that we can do, which we'll actually practice a bit in lab, where we can work on improving overall neck position through the use of like headlamps or lasers on their forehead, which you can kind of see in the picture here of this individual trying to take that laser and move it through this maze here without getting outside the lines. So that gives some good subtle information to the neck proprioceptors and kinesthetic receptors about how to keep that head in a proper position. The muscle group that's most commonly an issue with regards to neuromuscular reeducation is the deep neck flexors again. So not just a strength thing, but also a motor coordination type of thing, proprioceptive awareness issue happening with those deep neck flexors. Okay, sometimes it can be the neck extensors, but that's much less common because most of the time this is happening to somebody with a whiplash injury, and those deep neck flexors are inhibited more times than not. Let's move on to the vestibulo-ocular interventions. This is our second profile for the APTA MTBI CPG domains. Okay, so falling underneath this category would be our PCS categories of vestibular and the ocular visual profiles. Probably are going to land underneath this particular area. Okay, so from a vestibular standpoint, one of the most important things that you're going to want to do for this patient population is to determine if they have BPPV. If they have an inner ear dysfunction going on, you can identify that and engage in canalith repositioning techniques to improve that. And usually you'll see very significant improvement in their dizziness profile pretty quickly. All right. Make sure you rule out any sort of BPPV issue, and if it is present, correct it. You can usually get that done within 1 to 3 treatment sessions, and then that patient's going to start feeling a lot better pretty quickly, and then you can move on to other signs and symptoms. This is an individual that will commonly present with balance dysfunction. So it's important that you examine the patient for which types of balance dysfunction they have, what's the root cause for why they have balance issues, and then address them based on what they're presenting with. So I feel like throughout this program, you've had a lot of instructions on how to approach balance and how to engage in some interventions based on it. So we won't spend a ton of time on it, but just note that it's super important that this particular patient profiling, especially vestibular, that we get in there and work through some balance deficits. Okay. VOR we talked about in lab, so you kind of know what that test looks like. If you see an impairment there, you're going to have to work through it. Gaze stabilization exercises are typically the most indicated for someone that has an impairment of VOR. And then they may present with visual motion sensitivity. So in that particular case, then we'll start working on habituation techniques. Okay, so what we kind of see through here is a lot of, on this slide, a lot more interventions, approaches that are specific to the vestibular profile. Vestibular on this slide. Okay. It's also important to note that if the person has secondary cervical impairments, that can be a problem because a lot of the techniques that you're doing for vestibular therapy involve head motions and sometimes taking the neck into kind of more end range positions. If the person has a significant hypomobility of the neck or is having headache symptoms with neck motion, it may start to interfere with some of the rehab interventions you would use for the vestibular section. So even though their primary impairment category may be vestibular in nature, if that cervical spine is preventing you from being able to engage in the vestibular rehab you need to, then you may in fact need to address the cervical spine issues first before you can get to vestibular. So I just want you to have that note in mind because we've talked so much about, hey, first you're going to focus in on the primary category. But in this particular scenario, if the neck is a limiter of you being able to treat that vestibular dysfunction appropriately, then you've got to address the neck first before you can move on to the vestibular component. All right, let's talk a little bit more about the ocular component of things. Again, somebody that's having difficulties with maybe like smooth pursuit or the saccades that we've already talked about. Near point convergence would fall into this category. Usually that particular individual would benefit from visual rehabilitation training or VRT. Now, there are things that we can do as physical therapists for visual rehab training. There's a lot of things that we can do without referral, but if that patient is very severe or you don't feel comfortable yourself overseeing the visual rehab, then a referral to an ophthalmologist is necessary. The ophthalmologist may be very helpful into overseeing and implementing and progressing the visual rehab training, and they can also screen them for any sort of supplemental problems that they might have, such as prisms, which you might need for certain types of eye dysfunctions from the concussion. Some of the most common treatment interventions that we would use for visual rehab training include visual tracking exercises, something called pencil push-ups, and the Brock string are very good for near point of convergence and things of that nature. There's lots of great computerized programs that are out there that work on motor function of the eyes and things of that nature. So there's really great things that we can do to help somebody in the ocular profile. Again, just reminding you that if anybody falls in the dizziness and ocular visual categories, typically they tend to have a more prolonged recovery process, big picture. So this is definitely one that you don't want to be afraid to refer or to pull in more multidisciplinary help because that's going to be what's going to be best for the patient. Some other patient education considerations, much like we talked about with regards to the cognitive fatigue profile, you might want to make similar recommendations for the person that's in the ocular or even the vestibular component of things, but especially the ocular component of things. You want to limit those visual activities to shorter intervals. Again, maybe that's based a little bit time-wise on what their subsymptom thresholds are. But in general, you want to have shorter periods of time of visual activities with more frequent rest breaks so that they don't get that cognitive and visual strain. Okay. From an oculomotor standpoint, sometimes the patients will report double vision or blurry vision or jumping with the saccades as they're trying to do things like read. And so we tend to find using something like a line guide is really helpful. Maybe use like a ruler or something where you block out the words below it and you have the line with the words above it, and that tends to help them be able to filter out the other things going on around and kind of focus their attention onto the words. If they're really struggling with reading, this is the person maybe you want to encourage to switch to audio. If they're in school, maybe they can record lectures and listen to the lectures rather than read through the PowerPoint slides. So things along those nature where you can kind of tap into maybe some of the more auditory focus component of things and take down the amount of ocular demand that they have. Computer work can be an issue, especially if they have to do a lot of scrolling or scanning. Even the brightness from the screen can cause problems. So again, subsymptom thresholds become really important. Sensitivity to light, again, like we talked about with regards to the post-traumatic migraine profile, those fluorescent lights and the lights from the computers or phones, they're an issue. You may need to recommend blue light filtering or anything that kind of reduces their light exposure, because it can be definitely a trigger for people in this particular profile as well. All right, let's move on to exertional intolerance. It's interesting for this one. There's not a specific profile that's indicated for exertional intolerance interventions. Obviously, if somebody presents with a dysautonomia type response, then for sure we're going to pull this in. But that being said, anyone is actually appropriate to implement a progressive aerobic exercise training program. Aerobic training is one of the best things that you can do with any patient post-concussion syndrome. And so doing that Buffalo concussion treadmill test is really important, because that's what you're going to use to kind of set that threshold. Okay, so whatever they get on the Buffalo concussion treadmill test gets you that ballpark heart rate threshold, and then you can comfortably train that person at a percentage rate below it. Most of the research, I say, is somewhere between 80 to 90%. There's some discrepancies depending on the sources that you use. 85% is probably a good compromise to kind of key in on. But you want to be at least below 90% and above 80% of that heart rate threshold to really make improvements in their aerobic exercise and tolerance. Okay. Similar to what we have talked about in other things, we want to stop after the exacerbation of symptoms increase more than 2 points, or 1 if you're going to be a little bit more conservative. There's nothing wrong with that, but for sure no more than 2 points, or you get an abnormal heart rate response, which we'll talk about here in a minute. You want to train that individual at a steady state, so I'll show you what steady state look like, and then I'll show you what an abnormal heart rate response would be. Anybody that you're training with regards to exertional intolerance, I'm going to strongly recommend that you use some sort of reliable heart rate monitor, and you're going to want to actually use the monitor to detect when that abnormal heart rate response occurs. Sometimes the subjective report of symptoms increases in concert with that abnormal heart rate response, but sometimes that abnormal heart rate response happens first, and then there's a little bit of a delay for when they start recognizing the provoking of the symptoms that are associated with it. So you might be able to detect when to kind of stop or reduce down the intensity of the intervention more quickly if you have that heart rate monitor available. Okay. From a training standpoint, we want to get them into that 80 to 90% heart rate threshold and be able to improve their tolerance to about 20 minutes. When we can get to 20 minutes and their heart rate is steady state, there's no significant exacerbation of symptoms, they're at that 1 or less, then I think that's appropriate for us to reestablish a new heart rate threshold, and we can up the intensity of that exercise. But until they can get to that 20-minute mark for their tolerance to exertion, we're going to kind of live in that training protocol until they can do it. Okay. So what does a steady heart rate look like? Again, there's going to be a warm-up period to get their heart rate, more up to like that 65, 70% mark. And then we can increase the intensity to hit that 80, 85, 90%. And as they go through their training protocol, their heart rate should stay fairly similar. And you can kind of look through here and you can kind of see that there's not a lot of variance in their overall heart rate. But as we move into an abnormal finding, you'll see we did, some of the ramp up, and then we get into, actually doing the training, and already we're kind of seeing some issues with being able to have a nice steady rhythm. And then we reach a major threshold, and you can see that this person has a significant response where it's just not where we expected that jump to be, right? So here's a huge dramatic change. Something happened there. We need to calm it back down again. All right. So again, I feel like I've said this already, but I'm going to say it one more time because it's that important. A symptom-guided progressive aerobic exercise training program is indicated for all patients that have experienced a concussive event. It's not just for those who exhibit exertional intolerance, right? It's for anybody that has had a concussion. Aerobic exercise is indicated for everyone. It's going to help everyone regardless of their clinical profile. It's even important to do that in individuals that they're not even looking for vigorous activity. I'm not going to return to sport. You still want to encourage them to engage in aerobic activity and use their symptoms to guide how intense and how long you direct that engagement. And you can see some of the reasons why, among others, why you would do that. Okay. The last thing we'll talk about is the motor function intervention. This is appropriate more for when we start talking about balance deficits, which can occur in multiple different clinical profiles. So again, this isn't keyed in towards one profile. It's really to that person that's demonstrating a balance deficit in general, or a motor coordination deficit. Problems with hand-eye coordination would fall into this category as well. These are typically ones that you're getting closer to pushing towards that higher level functional performance. This may not be where you start, but it may be where you're getting to with this patient once you calm down some of their symptom provoking issues. So things like static balance deficits or dynamic balance deficits would fall into this. Like we said, coordination issues. Dual tasking becomes something that's really, really important for you to both assess and treat in this particular patient population, not just somebody that's in that cognitive profile. Anybody post-concussion will oftentimes present with dual tasking problems. So think back to the way you examine it, looking, back to like the mini best, the very end of it, or just isolating the tug. There's a regular tug, and then there's the tug cog. That asks them to, count backwards while doing the tug itself. That's a dual tasking assessment. That needs to be done to kind of gauge where they're at with their dual tasking. Then interventions that incorporate the physical skill with cognitive processing becomes really important to improve their overall function. Any sort of work or recreational or activity specific tasks would technically fall under the domain of motor function interventions. And so we'll have a lab that kind of works through some of the dual tasking kind of things and how you'd approach, higher level balance tasks and things of that nature. But I feel like this is an area, you should feel pretty strong with based on what you've had in the program thus far. Here's a list of our references. That was really the bulk of what we needed to talk through for part 4. There's a couple more slides afterwards if you're really interested in concussion, or if you're somebody that's a little bit more interested in graduated return to play. Maybe you're somebody that's thinking I might have something related to sport-related concussion management. There's a couple more pieces that I'll kind of talk through the rest of this, but from this point forward, it's just nice to know information. I'm happy to share it with you, but if you want to stop the presentation here, by all means, you should be ready to rock and roll for your IRATs and GRATs and all the other fun stuff to come. So thank you for listening. I appreciate it. For those of you that are staying on, let's talk about some nice to know information. Some of the concussion management guidelines on return to play began in 2016 more heavily with Collins et al. This was a really important seminal piece of work that established graduated return to play. You can see on the slide some of the big picture items that this particular research group recommends for how to manage concussion. A lot of these we still have in play today. When we talk about, somebody we suspect a concussion and, like a professional athlete, they're pulled from play. If we suspect, or even hopefully not, but if we do confirm the concussion, then they're not going back to play. They're done. We pulled them out. They need to recover. Okay. It needs to be done by a physician or other licensed appropriate healthcare provider on site. We need to use appropriate sideline tools. So again, think back to some of the things we did, like the SCAT5 would probably be a really strong sideline assessment tool for concussion assessment to use on the sideline. We talked about before, players should not be left alone. We need to monitor them serially because there could be some dramatic changes that happen. If they start to spiral downwards, then we need to get them that emergent medical care right away. Okay, here's where we get a little bit dicey here, this idea of cognitive and physical rest until asymptomatic. Again, we're going to use the word relative. It's not bed rest anymore. We need activity and moderation without symptom provocation, right? So you're going to have to gauge that sub-symptom threshold, do a good job of training that athlete on what that means and how to monitor what's going on with that, or somebody that's there to kind of help monitor that process, because that's going to be the type of cognitive and physical rest we're talking about. It's not bed rest. They're not going to return back to normal activity. They're going to return back to moderate level activity they can engage with without violating our established symptom threshold. Okay, and they may need accommodations, and we're going to get them back to aerobic-based activity first, sport-specific activity second, as their symptoms allow. Okay, here's a little bit of a table view of how they kind of gauged the graduated return to sport. Everybody would technically go through this particular 6-stage process. You don't skip any of the stages. It's really important that there be at least 24 hours of monitoring symptoms in between each step. If any of the symptoms worsen during the exercise or things don't go, then we go back to the previous one. They have to have 24 hours of doing this before they can move on to the next one. So stage 1, symptom limited activity. We're going to do those moderate activities that do not provoke symptoms. If we can kind of start to get them doing some of their daily life activities and they stay below that sub-symptom threshold for 24 hours, then we can move on to stage 2, where we're going to begin aerobic exercise, very light. Again, starting to just increase their heart rate, get them working with a little bit of aerobic activity. Resistance training is not indicated at this time. Just light aerobic tasks to begin with. If they can do that for 24 hours with no symptoms, then we move on to number 3, and so on and so forth. Okay, stage 4 is really where we'd strongly recommend starting some resistance training. There's some that say you can start that in 3, so we'll kind of give a little bit. Somewhere between 3 and 4, you can start resistance training. If you want to be conservative, I would pick 4. And then stage 5 is full contact practice. If they can do that well, then they're ready to return to sport. So this should really take about 10 to 14 days to progress through. And this is after they have that 24 to 48 hour time period of rest before we even start this particular protocol. Okay, so this is just kind of a slide that summarizes everything I just kind of talked through. So if you have questions about this or want to kind of talk through any of this, don't hesitate to reach out for me. Again, this is great if what you're thinking about is I really like sports, I want to get into sports, and concussion is something that I'm going to be having to figure out how to manage and work these athletes through in concert with their athletic trainers and their coaching staff and whatnot. Then you want to spend some time feeling comfortable with what some of these protocols are. This was the best one that I could find that kind of started the stage for it. And there's different ones out that you might see based on the specific physician that's overseeing, the team physician that's overseeing the return to sport might have a little bit different model, but it's still going to be kind of this similar style, if you will. Some other big picture things not really related to sports specifically, but that can come up is a couple of significant potential consequences of PCS. In particular, second impact syndrome. It's very controversial, but the thought process being that maybe we had a mild traumatic brain injury, and during that recovery period, we had a second impact or even a tertiary impact that created another mild traumatic brain injury while we were still recovering. And in some cases, those individuals can have a significant change in cerebral edema. And so you'll see, if you're monitoring it, a massive increase in their intracranial pressure. And unfortunately, with all that fluid underneath the skull with nowhere to go, can really cause some herniation and damage to the brain because of that response. There is some controversy of whether that happens or what it is. I can't get into that. All I can tell you is here's something that we know could potentially happen for this person. So this is, again, another reason why we're just going to strongly encourage that removal from play and allow that brain time to heal before we start engaging in some of that contact sport, so that they can prevent any, even though it's rare, any potential for second impact syndrome. There's also a thought process that long-term continued mild traumatic brain injuries over time can create CTE. And it's just a progressive neurodegenerative process that happens long term. So this is not a short-term issue like second impact syndrome. This is based on all these collective sublethal blows that we've taken to the head, that's created a mild traumatic brain injury, and that's occurred over and over again, has led to degeneration of brain tissue. Unfortunately, we can only really diagnose it post-mortem, so it's hard to detect. We need more information on it, and we don't know, does everybody that's been a boxer go through this? And we won't know that until, obviously, we can get in there and do it post-mortem. And so, these are things that, they exist in the literature, they exist in our conversations in healthcare, but it's a little bit controversial, and there's not a ton of information that we can clearly state this is going to happen, and here's our prediction that it's going to happen. These are things that are just possible, that we need to be careful of. And the better we can educate our patients on how to protect their brain and to fully heal and recover in between multiple concussions, the better off they're going to be at preventing something like CTE, right? We want to prevent multiple exposures of concussion to help prevent that. Here's a couple of resources, videos, and other things that can, if you're interested, you can watch on your own time, and give you a little bit more information from, not from a PT standpoint, but more from a medical standpoint of what they are and what we're doing about it and where things are going. So you can look through those at your own time. Have some other resources you can key in on if you're somebody that's like, hey, I'm interested in concussion, but I really want to do pediatrics. There are some different guidelines that we use when we're talking about very young individuals, and so on and so forth. So take a look at some of these resources if you're really interested. I'm happy to talk more about this kind of information, but all of this is kind of nice to know information, not stuff that you have to know to really be doing a good job as a PT for the basic population. But if concussion is something that you're really interested in, that you're thinking might be a population you might treat more significantly, then these are some good resources to kind of help you get where you want to be. I would highly encourage you to focus in on getting more of a concussion specialty clinical site, so you can see a lot of this in a context of how to manage this patient population. It's a fun thing to treat, but it's also challenging. It can be easy to get overwhelmed, not just from the standpoint of the patient, but from the standpoint of the clinician. So if you're interested in concussion, it's really a passion that you have, then I'm going to preach patience. Be as conservative as you can with this patient population. Better that they take their time and know that it's going to take time to recover, rather than push them too far and have them have setbacks. Those setbacks can cause real problems for the patient, both from a physical and from a biopsychosocial standpoint. So, preach patience. Stay organized, keep it simple, remember some of those overarching things, and seek anything where you can to help improve the overall quality of life for this person, whether it's function or mood related. Those are going to be big picture things that's going to work for you, along with reaching out to individuals that might help collaborate in the care of the patient. You do those things, you're going to set yourself up for a great concussion clinic environment for your patients. All right, that's all I have. This is really the end, so I'm not sure why you're still reading this. We're all done. Have a great day. Bye.